I'm Dennis Wagner. I'm the Director of the Quality Improvement and Innovation Group here at the Centers for Medicare and Medicaid Services.
And I'm Jeneen Iwugo, Deputy Director for the Quality Improvement and Innovation Group here at CMS.
There have been a lot of successes in the initial 24 months of the QIO 11 scope of work, and I'm going to touch on just a few. 325,000 patients immunized in the practices that are part of the immunization work, which is just beginning. We have QIOs who are taking, I would say, a very customer-centric approach to the work with the practice transformation networks that are part of TCPI. They're customizing the assessment work and their approach to those practices in close working partnership with PTNs. I'm delighted with that. We have, as of today, I'm told, 9,435 nursing homes. This is out of the 15,000 nursing homes in the country who are now are part of either the first round of the collaborative of the nursing homes or the second round. And the really exciting thing about that is that we are seeing improvements on many dimensions of the composite score that we're using to improve quality in nursing homes. So I think we're on the cusp of a major national success with the nursing home work, and I'm very, very excited at the role and the leadership that QIOs have had in generating some of those results and those successes.
With the BFCC program, the 5 regions and 2 contractors that we're working with have done an outstanding job of really representing strong what it means to be part of a beneficiary and family-centered program. We have enhanced the efficiency of the program, and we've had some really great wins, lessons learned with things that we've implemented like call centers, and we've taken on new work. The 2 midnight rule was a big surprise, but we're happy to have that work, and we're doing a great job making sure that the nation's healthcare providers are adhering to the standards of that very new legislation.
Yeah, and the administrator was particularly interested in bringing the QIOs into the 2 midnight reviews as a way of bringing additional clinical expertise to the work of making decisions about 2 midnight.
Yeah. In addition, we've created a BFCC dashboard, which has a robust set of data all about the work that the QIOs are doing, and then also forecasting how that work impacts beneficiaries, and showing the wealth and the strength of the data that we've had.
In addition to the work of the BFCC-QIOs, there has been a tremendous growth in CMS's investment in quality improvement overall. We have invested more than $650 million in the Transforming Clinical Practice Initiative. We're investing almost $400 million in the work of the Hospital Improvement and Innovation Networks, and we are consistently growing the scope and the breadth of the QIO 11 scope of work. And QIOs have been integrally involved in the Transforming Clinical Practice Initiative and in the work of the new Hospital Improvement and Innovation Networks. We're very proud that 2 of the QIN-QIOs are also prime contractors for the Hospital Improvement and Innovation Networks, and most of the other QIN-QIOs are subcontractors as part of the Hospital Improvement and Innovation Networks. This is exactly the design that we had in mind. We want to bring 2 powerful and influential networks together, and to do that as part of the home base of the Quality Improvement Organization program. It's been an exciting year with lots of growth and more to come. The launch of the Quality Payment Program, which is going to have a major impact on how over 600,000 clinicians across this nation are paid. It's critically important that we provide great technical assistance to these clinicians as they learn how to comply with the new Quality Payment Program. We want it to be as low burden and as easy as possible for these clinicians. Now, some of that work is going to be done through the Transforming Clinical Practice Initiative. About 140,000 clinicians will be supported through TCPI in their work on the merit-based incentive payment system. Another very large group of clinicians, maybe as large as 200,000, will be served by the new, we call it SURS, which stands for Small, Underserved, and Rural. These are practices that are small, that are in rural areas, and that serve the medically underserved. About 200,000 or so clinicians will be getting their technical assistance through this new program that was authorized under the statute. That leaves everyone else, and everyone else is a big number. That's 400,000 clinicians that we expect will receive their technical assistance for the new Quality Payment Program through the QIOs. We want to make it as easy as we possibly can for them to comply with the new payment requirements. But QIOs have really stepped up and kind of flexed with us to design a program of work to serve these 400,000 or more clinicians.
And I would just say that the technical assistance that we're doing throughout the nation with the planned scope of work, but then also the addition of the new technical assistance tasks that we've added are all about us meeting the demand, being asked and called to help providers, and we've met those demands, we've said yes, and we've stepped up to the plate to team with whoever's calling, whoever's asking to provide technical assistance in the area where it's most needed.
Customer service, that's a whole new thing for CMS in some ways. Yep. So in our work here at CMS to team with quality improvement organizations, we are trying very hard to implement a philosophy or an approach to our work that we call flexible tight. And the principle here, which we've talked a lot about with the QIOs and with many clinicians and other healthcare organizations across the United States, is to be very tight on the outcomes, the health improvements, the cost savings, the customer service benchmarks that we have in place, to hold ourselves accountable and to be tight in our focus on those outcomes. But at the same time, to be flexible on the how part. We want to tap into the creativity, the extensive experience, the expertise of quality improvement organizations and their staff, and really kind of unleash that ability to be very flexible on the how, but to be very tight on the what. That's our aim. That's really at the core of the way that we're trying to team and lead with quality improvement organizations in providing support to nursing homes, to hospitals, to home health, to clinical practices, and to others.
In addition, I would say we're also perfectly poised to be great collaborators. Like, we want the QIO to be in the middle of those who need help, those who are receivers of healthcare, and the providers of that healthcare. And we want the QIOs perfectly sandwiched as the hub in between all of what's going on in healthcare, so that they are involved, they can make connections, they can introduce people and organizations to each other, and they can keep CMS as the frontier organization that's a great collaborator of healthcare organizations.
I think we learned some important lessons with the Partnership for Patients. QIOs were an integral element of that. Hospital engagement networks were an integral element of that. And now in the new combined hospital improvement and innovation networks, we're trying to extend that philosophy forward. So what is it that we learn? Well, I think one of the things is that bold, ambitious aims attract people. They bring people in. People don't want business as usual. We want to make things much better. And when you set an ambitious aim, like a 40% reduction in preventable harm and a 20% reduction in 30-day readmissions, that attracts people. The other thing we learn is that we can achieve these results. After 4 years of work, we've generated together a 39% reduction in preventable harm. That equates to 2.1 million fewer harms in hospitals, an estimated 87,000 lives saved, and $19.8 billion in cost savings. So what do you do when you achieve results like that? Well, what we're doing through the new Hospital Improvement Innovation Networks is we're setting new, bolder goals. We've now established a goal of a 20% overall reduction in harm, not just preventable harm, a 20% reduction in overall harm, and a further 12% reduction in readmissions from the new calendar year 2014 baseline. We are excited about these goals, and we know they're going to be tough to achieve, but we're confident that the clinicians in hospitals working together with quality improvement organizations, the new Hospital Improvement and Innovation Networks, are going to achieve these results. I think one of the new things that we have that I'm excited about is that we are now holding ourselves here at CMS, here in the Department of Health and Human Services, and I would say as clinicians and caregivers and healthcare organizations across the country, we're holding ourselves to new standards: better care, better health, and smarter spending. The patients and the citizens of this country are really depending on us to do that, to provide better care, to provide better health, and to do it for less money, not more. And that's exciting work, and we're at the very cutting edge of that exciting work.
And sometimes that means that we're on the road less traveled. We tell people that all the time. We're not taking the easy route here. We're not taking the path of least resistance. We're taking the route that is the most innovative, that's going to have the most opportunity for improvement, and that's going to have the most impact.
You know, Jeneen, I love what you said about living in the red. I think taking the road less traveled, picking the hard path when there is a path of least resistance, and then living with some of those failures, living with some of that red, that is really key to quality improvement. You have to be able to do that, and we're grateful to be in partnership with the quality improvement organizations and the QIO program in that kind of an approach to exciting work. Thank you.
Thank you.